This program is brought to you by Emory University.
All right. Hi, good morning, everyone. It is my pleasure this morning to introduce one of our own, Dr. Jonathan Kim, who is an associate professor and founding director of sports cardiology in the Division of Cardiology and Orthopedics here at Emory. He's also an adjunct faculty in the School of Applied Physiology at Georgia Tech. Jonathan went to undergrad at Emory and was a Fulbright scholar, followed by his medical school at Vanderbilt. This was pretty unique. I thought that he did an internal medicine and pediatrics residency at Mass General, followed by his cardiology fellowship at Emory, and he was a chief fellow here. Jonathan had a K23 in the area of sports cardiology and subsequently has an R01 in this area. As we probably know, he's also the team cardiologist for major Atlanta teams, including the Braves, Hawks, Falcons, Dream. He serves on the cardiac advisory board for the NBA and the cardiovascular task force for the NFL. Jonathan is a current chair of the ACC Sports and Exercise Cardiology Council and also the co-medical director for the Peachtree Road Race. So without further ado, Jonathan Kim, he's going to talk to us today about changing landscapes within sports cardiology.
Thanks for that introduction, Pooja, and good morning to everyone virtually. It is always a pleasure to give cardiovascular grand rounds here at Emory. And today I'm going to talk about changing landscapes within sports cardiology. And this is really a perfect time to give this topic. Over the last 10 years, there's been such an explosion of science within this field. And maybe more important than anything else, a change in philosophical approach, which is a key part of the talk this morning. So you heard my affiliations, my research funding, all relevant to the cardiac care of athletes, but no other relevant disclosures. So my objectives this morning, the first two are highly intertwined. We're going to talk about sports eligibility considerations for competitive athletes with CV abnormalities and disease. And that's very much a part of this philosophical change in approach. Out with the old, you can see the cartoon noting medical paternalism, and in with the new, embracing uncertainty and embracing shared decision-making. We are going to jump through a few bins in sports cardiology, not necessarily related, but I want to talk about masters athletes and ASCVD risk as well. And the reason why many of the young competitive athletes will find their way to a specific sports cardiology practice, but masters athletes will diffuse throughout all cardiology practices. So I want to talk about some of the unique considerations within this population and some potential challenges to consider. And then lastly, challenges yet to tackle. We have plenty of uncertainties in this field that are old, and we still don't have all the right answers. But as we look to the future, new challenges to address that I think are important. I'm going to specifically focus on one that I think has become quite relevant over the last year or so. To begin with, just as a general overview, I mentioned that there's been such an explosion in this field. And I showed this slide just to coincide with various JACC state-of-the-art reviews that have been published by our council over the last 10 years, beginning with the introduction of the sports cardiologist as a key member of the athlete healthcare team, noting the key curricula that all sports cardiologists must be familiar with in terms of unique aspects in the population of competitive athletes. Most recently, a couple of years ago, we wrote another review talking about aspects of exercise-induced cardiac remodeling, but also talking about some of the challenges of managing complex cardiac issues in athletes, as well as the shift to shared decision-making. We've had guidelines since over the last decade. In 2017, the publication of the International ECG Criteria for Athletes, and for those who aren't aware, hopefully everybody is, the interpretation of the athletic ECG certainly comes with differences compared to the general population. And all of us are also aware that over the last 30 plus years, we've had various iterations of sports eligibility recommendations, specifically for athletes with cardiac conditions. These are the old Bethesda Conference proceedings, the first published in 1985. Here I'm showing the 1994 and 2005 updates. And most recently in 2015, the shift to an AHA-ACC scientific statement. Importantly, though, over this 30-year time frame, the overall philosophy was the same. You can see it in the title here, eligibility and disqualification recommendations for competitive athletes, very much having a line in the sand, this medical paternalism, even in situations where uncertainty was present. And I just show this paragraph here. This comes from the HCM task force on genetic cardiomyopathies. And I'll just paraphrase to summarize what they said. They note that these recommendations are conservative, but quote unquote prudent, that should be applied in a homogeneous fashion across the broad HCM disease spectrum. And they note that actually they acknowledge that this could result in disqualification of some athletes who could be low risk and maybe unlikely to ever experience any sort of acute cardiac catastrophe. But they felt that the disease was so high risk, they had to draw this line in the sand for all athletes across the board. The question, of course, is, did the data actually support that, or does the data currently support that? Well, let's talk about shared decision making. I think it actually dates back to the mid-90s, whenever there's the first hint of where we are today. And it goes back to the famous Nick Knapp versus Northwestern case. For those who don't know, Nick Knapp was a basketball player at a full ride to play for Northwestern. But prior to his matriculation, he was diagnosed with HCM. He had a defibrillator placed, and ultimately Northwestern disqualified him under medical grounds. Mr. Knapp sued for his right to play, but ultimately the U.S. Court of Appeals favored on the side of Northwestern, stating based on the medical guidance, medical guidance at the time, Northwestern was within their right to disqualify Mr. Knapp. But they kind of set the stage for where we are today. They note that not all universities could potentially view this case the same way as Northwestern. And when we think about disqualification, there are clearly downsides to athletic restriction. Obviously, physical inactivity and the risk of potential later life cardiovascular disease. But for young competitive athletes, we have to think about the psychological stresses as well. Risk of depression, drug abuse, even suicide. And these are very real world issues that don't get talked enough about, particularly when comparing to the potential risk of an overall rare outcome of sudden cardiac death. I actually had the opportunity to meet Nick Knapp. This is AHA this year in Philadelphia. He's the gentleman in the blue tie. Omar Carter is the gentleman in the blue blazer. And what struck me, particularly with Mr. Knapp's talk, was how he described how he felt back in the 90s. Nobody cared about what he wanted to do. His voice, his values were completely excluded from the discussion. And after hearing that, it was really quite moving, and certainly reinforces the shift to shared decision-making, in my opinion, that this is clearly the right approach as we deal with these cases today. So shared decision-making is certainly the pinnacle of patient-centered care, not just in sports cardiology, but throughout. But within sports cardiology, it's not just the ethical imperative that we need to include this when we counsel the athletes we care for, but we have data now. So these are actually older studies, but we now know that in conditions or situations where previously was felt to be completely high risk, it was a universal disqualification for congenital long QT syndrome, athletes with ICDs. We know that under appropriate guidance based on data, that these athletes do quite well without any sort of risk for an adverse outcome. So the landscape has changed for other situations where there is medical uncertainty. We discussed the pillars of shared decision-making in the most recent state-of-the-art review that we wrote a couple of years ago. And we emphasized the importance of knowledge. Clearly, you have to know the diagnosis, the condition. You have to have expertise in terms of the interaction between exercise and the cardiac condition that is currently being discussed. Have to have humility, have to know when to ask for help. I think the most important part of this is respect as it pertains to shared decision-making with athletes. We have to respect the patient's voice and include their values within these discussions. And then certainly teamwork, working with other key stakeholders, a part of the discussion, and communication with all parties throughout. But we have new data now as well. So for those who were at ACC this year are likely familiar with the presentation of the LIV HCM trial. So this group was led by Rachel Lampert, who was just here at Cardiovascular Going Rounds a few weeks ago. And in this trial, they looked at around 700 individuals with HCM who participated in vigorous exercise, and they compared them to other individuals with HCM who are either sedentary or participated in only moderate forms of exercise. The primary outcome was a composite outcome of either sudden death, cardiac arrest, placement of a defibrillator, or arrhythmogenic syncope. And you can see the Kaplan-Meier curves here almost superimpose the hazard ratio 1.01. No difference in risk in terms of those individuals who are exercising more vigorously compared to those who were just moderately active. Now, there are limitations. The study was not representative of all patients with HCM. And certainly there's the concern that most of these individuals were cared for at high-level centers of excellence. Vigorous exercise was really consistent with only AHA physical activity guidelines for vigorous type exercise activity. And generalizability, while the individuals who were engaged in vigorous exercise were highly active and did include some competitive athletes, the generalizability to all competitive athletes not firmly established. Now, at ACC this year, there was a second study that was presented, and these were outcomes of high-level athletes who returned to play with various underlying genetic heart disease conditions. There were 76 athletes, either NCAA Division I, or professional athletes. The most common conditions were long QT or HCM, but there are other various genetic heart disease conditions included as well. And these athletes were followed for outcomes after they decided to return to play. And importantly, these were not cherry-picked low-risk individuals. 10% had a prior history of cardiac arrest, and a third of the cohort already had an ICD implant. Overall, over 200 athlete years of follow-up were included. It was about 8 years of follow-up. And you can see there were only 3 athletes that had breakthrough cardiac events, only one of which occurred during exercise. And there were no cases of sudden cardiac death. So that's a breakthrough cardiac event rate of around 4%, which is clearly not prohibitive and suggests that under appropriate care, athletes who choose to return to play with underlying high-risk conditions actually can do it potentially in a safe manner. Now, I actually had the chance to write the accompanying editorial for this study, and I pointed out a few other important aspects. Number one, 72% of those 76 athletes were initially disqualified. So while we embrace this return to an approach of shared decision-making, it's important to note that this certainly is not applied across the board at present. Shared decision-making is not a rubber stamp. So as sports cardiologists, we can't abrogate our primary duty to advise when we think risk is high, and that has to be included as part of the shared decision-making discussion. I think this may be the most important generalizability. These were NCAA D1 athletes, pro athletes who clearly have resources, healthcare resources at their fingertips. So what about the athletes who come from underserved neighborhoods or universities who don't have the same level of resource access? So the concern of healthcare disparities certainly comes into play, and we can't generalize these data across the board. There may be institutional bias. These are all high-level sports cardiology centers. And really, we just need more overall outcomes data. And so I'm going to talk about the ORCA registry. Actually, this is the last slide of this talk. Well, the emphasis on shared decision-making also comes with challenges, as we don't have yet the science to really guide an evidence-based approach. So this is an editorial that I had the privilege of writing with Dr. Dickert here, and we published this about a year ago. And what we emphasize is that there are differences here. So this is shared decision-making, not for medical treatment options, but shared decision-making for a lifestyle option. And the primary outcome of interest is obviously quite rare, that being sudden cardiac death. So there can be some pitfalls that get in the way, differences in risk interpretation between the physician and the athlete, differences in risk perception for the athlete, and how does the physician actually place value on the lifestyle of competitive exercise for the patient that they're trying to guide this decision. And when any of these pitfalls comes into play, then of course, the desired outcome of an athlete-centered outcome can be jeopardized. So ultimately what we need is a better focused qualitative science focused on more evidence-based solutions to really guide this process. So the athlete who's seeing a sports cardiologist at the high-level academic center is getting relative similar quality to the athlete who is seen perhaps not in a big city, not at a high-level academic center, but with a general sports cardiologist in private practice. That has to be a point of emphasis. But I think it is fair to say that the future ain't what it used to be. So we love these famous yogiisms, and I do think it's quite apropos in this context. And I'll just give 3 more contemporary examples. Keontae Johnson, basketball player at the University of Florida, had a sudden cardiac arrest on live national television. He's currently playing professional basketball in the NBA. Christian Eriksen, again, another live SCA on TV, live on the pitch. He's back playing professional soccer with an ICD in place. And Jared Butler, who played college basketball at Baylor, he publicly disclosed that he had a diagnosis of hypertrophic cardiomyopathy. He, as well, is currently playing professional basketball. So 10 years ago, clearly all three of these cases, none of these young men would be back playing the sport that they love and really pursuing the lifestyle that really was their dream for their entire life. Well, with athletes who are now actually getting back to play with underlying cardiac conditions, and certainly if we talk about cardiac prevention, I don't care if you include a pre-participation ECG or if you're echoing every one of your athletes, certainly we'll never be able to prevent all cases of SCA. So I intentionally put this slide in because I do think it's a critical point of emphasis. This is where there is no debate in the care of young competitive athletes, the emphasis on an emergency action plan. And it begins with SCA awareness. You have to know what it looks like. We tip our hat to the trainers out there, particularly recent cases, Damar Hamlin, Bronny James, clear recognition, immediate CPR, immediate access to that AED, saved both of those young men's lives. The plan has to be written and it has to be distributed, it has to be rehearsed and practiced regularly. And of course, there must be a focus on CPR training for coaches and other individuals who interact with young athletes. These are the core tenets of an effective emergency action plan. And I want to acknowledge all of the national efforts that are moving forward from a legislative front this year. This all after the Damar Hamlin event, and really he and his foundation have really shined a national light on this. For those who aren't aware, there is the Access to AEDs Act, which is before Congress right now, and this will provide more access to AEDs for high schools across the country. The National Football League Smart Heart Sports Coalition was brought forward after the Damar Hamlin event. It's sponsored by every major professional sporting league. Major health corps organizations such as ACC, AHA, and the Red Cross are all co-sponsors of this program. And this is a legislative push at the state level, pushing forward three key laws. You have to have an AED at all high schools. You have to have an emergency action plan that's written, and there has to be CPR training for coaches. Believe it or not, while it sounds obvious, perhaps that everybody would have this in place, only 7 states in the US have all 3 of these laws present. The other 43, they may have some combination, but they lack actually having all 3. Now, it turns out actually Georgia is one of the states that actually has all 3 laws in place. But what we did as part of the Georgia ACC chapters, we went back and we looked where the gaps are. Some of the key questions: is there an EAP practice plan in place? Do people know what they're doing? Do people know if the battery is actually even working for the AED, or where the AED is located within schools? And what you find actually is there's clearly gaps. So this is actually an initiative that we're working forward right now. I helped write up legislation for this with colleagues, and we actually testified before the Georgia House Health and Human Services Committee last week. There's key support for this. They're obviously taking it from here, and hopefully within the coming months, this may actually be something that moves forward within our state and can certainly be a model for other states once they achieve all 3 of these key pieces of legislation. We hope that the momentum behind the EAP and access to AEDs certainly continues in this country. And as mentioned, if you didn't quite notice, just going through the 2015 AHA-ACC update, these considerations are really all outdated. And at present, we are working on updates. I have the honor of actually chairing this process along with colleagues around the world. And what I think you'll find is actually a thunderbolt once we finish this, is probably about a year away. But the emphasis on shared decision-making, a clear shift from how these documents have been written over the prior 30 years. And I do think it'll make it'll change the paradigm significantly and certainly place the value back to the athlete as it pertains to sports eligibility in the context of underlying cardiac disease. So I'm going to shift gears now. We're going to talk about the masters athlete. And as mentioned, it's really important because these are the individuals that certainly are percolated throughout all cardiology practices out there, not just within sports cardiology. So some may be aware of the old Basler hypothesis. So Dr. Thomas Basler was very interested in terms of outcomes of cardiac death, or sudden death, I should say, and the potential association with ASCVD. And he was a bit biased, though. He felt that marathon runners were probably more healthy than they really are, that they don't smoke, they eat the healthiest diets. So he went and looked at outcomes of sudden death. This was a case series that he published. And what he ultimately found actually was that, at least what he concluded, was that there were no cases due to underlying coronary atherosclerosis, and concluded that masters athletes, marathon runners, perhaps earned lifelong protection against ASCVD. Now, with all due respect to Dr. Basler, this is actually almost a joke of a case series. Almost none of these cases actually had autopsies. And one example that was included was Phidippides himself. So not surprisingly, this was quickly debunked within a couple years. And clearly we know there's plenty of underlying cardiac risk in this population. And these are the extremes. These are the cases that we see every day in the sports cardiology clinics. I did not personally take care of Jim Fix, the gentleman in the black and white, but certainly have patients that he representative of his profile. A lot of underlying risk. He had a strong family history. He was formerly overweight and a former smoker. And actually, even after he shifted to a life of running and wrote the complete book of running, he continued to eat quite poorly. And he unfortunately had a sudden cardiac death event while running due to acute MI. But this is a patient of mine on the right. This is a state champion recreational cyclist, really quite healthy, but his PCP decided just to check a calcium score, turned out to be quite high. So of course, how do you manage the high calcium score in the setting of low cardiac risk? So again, classic examples either by personality or by some of the challenge that these individuals present with when they come to the sports cardiology practice. But the first question to ask, so why the emphasis? Why should we care about this population in terms of a potential difference relative to any other patient that we care for in preventive cardiology? Well, first, there's the exercise paradox. We know that habitual exercise is protective from later life cardiovascular disease. But for those who have underlying subclinical disease, there is a transiently acute increase in risk of a precipitation of a cardiac event during vigorous exercise. Paul Thompson showed this in joggers that were jogging in Rhode Island over a 6-year time frame. And we showed this as well. This is our registry of sudden cardiac risk cases of half marathon and marathon runners. And while SCA was overall relatively rare for the masters athlete, those aged older than 35, almost all cases were due to underlying ischemic heart disease. And as mentioned, there are plenty of risk factors within this population. Not only that, but there's some stereotypes that are quite common within this population. Either ongoing carefree lifestyle habits, prior carefree lifestyle habits, the classic stereotype, the individual to get away from a former lifestyle of some of these lifestyle habits now becomes addicted to exercise. Plenty of family history within this population. I always tell my patients, you can't outrun your genes if you have some of these. Poor training habits, running while sick, and perhaps most commonly, poor diet. These individuals obviously feel great, they look great, and they feel like they can get away with it and eat whatever they want. And certainly all of these risk factors can be common within this population. Underneath that, there's a growing controversy that perhaps ongoing and a lifestyle of ultra endurance exercise may be its own potential risk factor towards the development of subclinical coronary disease. Let's run through the data. This was the first study published 15 years ago, incorporated a little over 100 healthy male marathon runners. The inclusion criteria are really not that rigorous. You just had to have run a few marathons. They controlled these individuals to age and Framingham risk score match controls and found higher CAC scores. But there was a lot of contamination of traditional CV risk. Half the marathon runner cohort were former smokers, and they didn't control for a family history. So not surprisingly, for these 4 individuals who had cardiac events over the subsequent couple years, a lot of traditional cardiovascular risk, former smokers, uncontrolled blood pressure, uncontrolled lipids. So we couldn't really take away anything from some of this, at least this initial study. Now, moving forward, the first attempt was to identify better inclusion criteria. And so studies began to account for both exercise volume and intensity as defined by METS minutes per week. So this was a Dutch study of 280 white male athletes. And the other key criticism really of all these studies is very poor diversity. But they looked at those who had very high exercise dose habits and compared them to low exercise dose habits and found higher calcium scores. Both exercise intensity and volume were associated with the development of stable calcific plaque, fairly similar to the Mollenkamp study. But again, they didn't quite account for traditional cardiovascular risk, half the cohort being former smokers. And while they did account for family history, not insignificant prevalence of a family history of early coronary heart disease. At the same time, in 2017, this study was published in the United Kingdom, and this was the first study that really accounted for baseline traditional CV risk. The mean Framingham risk score within this cohort was about 4%. These were 150 masters athletes. They didn't account for exercise in minutes per week. This is all based on hours of exercise per week, whether you are a runner or a cyclist. And these individuals were recruited through magazine advertisements, et cetera. And they compared them to a low risk control cohort. And while calcium scores of 0 were of similar prevalence between the two cohorts, it was only the male masters athletes who had high calcium scores or who had luminal stenoses greater than 50%. Now, importantly, plaques, again, here were more stable and calcific in nature. Now, moving forward, the question then being, well, what about outcomes? And that's obviously one of the key limitations that exists for all of these studies, is the fact that most of these were all cross-sectional. So what can we say about individuals who exercise at a high dose but who have high calcium scores? Well, these are data from the Cooper Center longitudinal study led by Dr. Ben Levine. This was a registry of 21,000 men. No women were included because there weren't enough all-cause or cardiovascular disease events. They were able to quantify exercise dose by both volume and intensity, again in METs minutes per week. And there were 1,500 individuals who exercised at greater than 3,000 METs minutes per week, which is equivalent to an individual on a marathon training program. The first thing they observed, there was about an 11% increased risk of having a higher calcium score for those who exercise at the highest dose. Now, Dr. Levine would be the first to point out that if you look at those individuals stratified by exercise dose who had a high calcium score, there was actually no difference in terms of the absolute calcium score. But this study was all about outcomes. For those individuals who engaged in the highest exercise dose and who had a low calcium score, a 50% reduction in both all-cause and cardiovascular disease mortality. But for those who had a high calcium score, still there was no difference in terms of all-cause or cardiovascular disease mortality, which suggests that for those individuals who had high calcium scores and continued to engage at the highest exercise dose, that didn't increase their risk of precipitating an acute cardiac event. Now, that's not to discount, obviously, the importance of coronary calcium. Here we see that whether you were an individual engaged in the lowest exercise dose or the highest exercise dose, there was a suggestion, this didn't reach statistical significance, but the suggestion of having higher all-cause as well as cardiovascular disease events. But that really is no surprise, right? We obviously know that having a 0 calcium score is better than having any calcium score. But what can we say about the protective effects of high cardiorespiratory fitness? More data from the Cooper Center longitudinal study. These are data of about 8,400 men who were followed for roughly 8+ years. They all had a baseline calcium score and an exercise test to estimate MET level of fitness. Through their modeling, they were able to estimate the risk of having an acute cardiac event up to the age of 70. So I'm going to focus here on the right side of the panel. And what's interesting is that if you're an individual who had a very high calcium score, at least greater than 400, and had the highest level of fitness, your risk of having an adverse cardiac event, which was defined as cardiac mortality, non-fatal MI, stroke, or revascularization, was 60% lower compared to a more sedentary individual. Another way to interpret this, if you are a highly fit individual with a high calcium score, your risk of an acute cardiac event was still about the same as a more sedentary individual with a calcium score much lower than 100 or so. So actually the worst thing you can do is to counsel this individual to stop exercising or to substantially reduce their exercise habits, as that may actually increase the risk of later life of having an acute cardiovascular event later down the road. Let's finish this off with some more recent data from this year, looking at the prevalence of subclinical athero in masters athletes. These were data from the Mark II study, Dutch athletes, again, all white male, so lacking the diversity that we would hope to have for an additional 6 years. This was not a blinded observational follow-up. But they were interested in whether it was exercise volume or intensity that was associated with the development of calcific plaque. And what they found actually was that it was exercise intensity. MET level of exercise intensity greater than 9 METs that was associated, as you can see here in panel C, with the development of calcific plaque. Exercise volume, or other degrees of exercise intensity were not associated with the development of any other type of plaque. But this study did have some similar limitations to some of the prior analyses. As you can see, half the cohort still were former smokers, mean blood pressure at follow-up within stage 1 hypertension. And there was a significant increase in those who began to take statins. And as we all know, statins increase your calcium score. But they conclude that it perhaps could be exercise intensity that may be associated with the development of calcific plaque. That leads us to the Masters Athlete Heart Study. I would submit that this is probably the most rigorous study to date that has looked at this specific question. And these data were presented at ACC earlier this year as well. They looked at 190 lifelong Masters athletes. So these individuals were not defined by minutes per week of exercise dose. Again, it was lifelong exercise habits, hours per week of exercise, whether you're a runner or a cyclist. And they compared them to individuals who began the habit after the age of 30 and then a control cohort. Again, these were only all white men. But this was a highly selected cohort. Nobody was on a statin. Nobody was on an antihypertensive, no underlying CV risk factors. And the strength of this study, they actually had around 1,200 individuals that fulfilled potentially these study group cohorts. So they randomized individuals into these 3 cohorts, which really, for the first time, accounted for potential selection bias. Now, this was a highly conditioned cohort. As you can see, even the controls had a mean peak VO2 greater than 120% predicted. And they were interested in the adjusted absolute prevalence of each of these specific type of plaque. So these are some busy figures. I'll talk you through it. Basically, what they found, those lifelong Masters endurance athletes had a higher prevalence of any type of plaque, proximal plaque, as well as stenotic plaque. And looking specifically at calcific versus non-calcific versus mixed plaque, with a lifelong Masters endurance athletes had a higher prevalence of proximal calcific plaque, proximal non-calcific plaque, and while it did not reach statistical significance, overall higher mixed plaque as well. So the authors conclude that contrary to what was previously believed, perhaps plaque composition in lifelong Masters endurance athletes not quite as stable as previously thought. Now, before all of us in the sports cardiology world panicked and certainly had a lot of angst over these data, we do need to point out some key limitations. Most importantly, again, the fact these are all cross-sectional data, lack of longitudinal outcomes, and we do acknowledge that overall, those who are engaged in endurance exercise, particularly even ultra-endurance exercise across the lifespan, tend to do better than everybody else. The cross-sectional nature of the analysis, the concern for confounders, and particularly dietary confounders. I have to say that my own, at least, thought within this population is that when you think about not only just baseline diets, but diets that are required to maintain ultra levels of training, a lot of complex carbohydrates, a lot of other unhealthy substances, who knows how that actually comes into play as it pertains to the associations between the development of underlying coronary atherosclerosis. So in the end, I think the other key question is you have to ask yourself, why is this individual an ultra endurance athlete in the first place? I have yet to meet a marathon runner or a triathlete who tells me that they like to engage in these habits to fulfill AHA physical activity guidelines. So the question of motivation is critically important. And I think this goes back to the importance of shared decision-making. Again, we have to incorporate the values of the specific individual when we're counseling them, and also as it pertains to the management of the patient, and noting the limitations of the data that we still are aware of. But whenever we discover underlying subclinical atherosclerosis, clearly we're going to initiate both lifestyle modification counseling as well as optimal medical therapy counseling, and that includes statin therapy. So again, another stereotype. Whenever I interact with these individuals, many times there's a hesitation. And I say, I think we need to start statins. There's a look. Doc, I don't know, I hear terrible things about statins. So what do we know about statins in Masters endurance athletes? Well, here are some of the data looking at statins in athletic populations. Some of these data old and fairly limited. This was a study from 1997 of 22 pro athletes who had FH, and a high percentage of these individuals complained of myalgias. Perhaps it's some of these older studies where some of these biases still come into play as it relates to athletes in fear of statins. The Primo study, again, a high prevalence of highly active individuals on statins complained of myalgias compared to those who are not as active. We know there may be a higher degree of muscle injury after completion of an ultra endurance event. This was a study of marathon runners after the Boston Marathon. Those who are on statins had higher CK levels compared to those who were not on statins. And the question of statins and impaired exercise tolerance, here where the data are a little bit conflicted, but I think the STOMP study here, published in Circulation and led by Paul Thompson, this was published in 2013, really answered the question. This was a randomized double-blind placebo-controlled trial. And what the authors found, those individuals on statins tended to complain of myalgias more often, but most importantly, there was no difference in strength or peak VO2 in those individuals who are maintained on statin therapy. So it does not alter your overall aerobic exercise capacity. And then many of you probably saw this study published earlier this year, ultra walking events. The group was interested in muscle injury and statin users versus non-statin users. And overall, they found no difference in biomarkers looking at muscle injury for those individuals who are on statins compared to those not on statins. So if we were to summarize, perhaps athletes tend to complain of myalgias more often. There may be a higher degree of muscle injury after completion of an ultra endurance event, but really no data to support that there's impaired exercise capacity for those individuals on statins. The bottom line, though, are these individuals present to us in clinic. And so how do we address that individual says, doc, you know what, I just can't tolerate this drug. I'm getting cramps, a lot of myalgias, muscle aches, et cetera. Well, I've had the privilege over the years to get to know Dr. Thompson, consider him actually a good friend of mine. And I listened to his words of wisdom he gave me years ago. First, which is that you get your biggest bang for your buck at the lowest dose of statin therapy. So a trial could be initiating statins every other day in conjunction with ezetimibe. But we're also aware that we have much more pharmacotherapy armamentarium at our disposal now than we did 8-10 years ago, whether it's PCSK9 or bempedoic acid. So we do have a lot of alternatives to counsel these individuals who clearly require some form of lipid lowering therapy. So generalized considerations for this population. Of course, we have to consider the standard traditional cardiovascular stuff that we do with every patient. Take a deeper dive into some of these master athlete risk factors. They are a unique population to work through. Family history, just as important as it is in anyone else. But the question of routine calcium score, should I get that calcium score for even my low risk masters athlete after the age of 50? Will you tighten that screw? Perhaps. But I do think we want to carefully consider that question because we can learn from data obtained from the general population, whether it's Eisner or Dan Kavis. There's really never been studies that have demonstrated positive downstream outcomes for screening very overall healthy individuals. So I find it hard to believe that for the low risk masters endurance athlete, we're really going to change outcomes by getting routine calcium scores. And ultimately, in the end, you got to be careful of that rabbit hole that you may be digging by getting that first test with that patient. So it's not advisable. We have to acknowledge the uncertainties that still exist within this population, even within good data such as the Masters Athlete Heart Study. So it really gets back again to shared decision-making, taking into account the motivations, the values of this population as we're counseling them. And for me, it's really always been about the opportunity, not just counseling for appropriate lifestyle modifications, as well as pharmacotherapy, if indicated, but also education. So what are the symptoms as a master's endurance athlete that I need to watch out for that may necessitate a little bit of a deeper dive into clinical investigation? So moving forward to the last part of this talk. So this is that future direction, some of the critical uncertainties that exist out there in the field. And what I really want to focus on, something that I think has been ignored in our field that's really coming to a head, is the issue of disparities within a young competitive athletic population. And I think you can appreciate this when you take a deeper dive into some of the epidemiological data that exists. So the question of how common is sudden cardiac death in a young athlete is a complicated question. And some of the data out there are certainly limited in terms of answering that question. I always cite data from the NCAA. I think these are some of the most rigorous data because the denominator is well defined and the numerator is well ascertained in terms of how they were able to adjudicate cases. So these data have been driven by Kim Harmon and John Dresner at the University of Washington. They actually just updated the data and presented the 20-year NCAA data at AHA. This is from 2015 and the 10-year results. They looked at all deaths over a 10-year time frame. They affirmed that the most common medical cause of death was sudden cardiac death with an incidence of about 1 in 53,000. The data, the incidence has actually improved a little bit. It's about 1 in 60,000 now when you look at the 20-year results. But still, males are at higher risk compared to females as it pertains to risk of sudden death. But the observation that young Black athletes are at higher risk of sudden cardiac death compared to white athletes has been demonstrated in this study as well as others. And when you look at specific sports, while being careful as you're now looking at a much smaller denominator, so case rates can certainly be inflated, but it does appear that men's basketball is of higher risk compared to other sports. Basketball, football, and soccer are the three highest risk sports, but basketball certainly the highest risk sport. And this observation of risk among young Black athletes has also been shown in other analyses as well. But the key point to remember is we don't know why. So underlying reasons as to why young Black athletes are at higher risk of sudden death compared to white athletes is unknown. But this does certainly mirror what we observe in the general population. And what we need to be careful of is jumping to potential biological predispositions and acknowledge that actually disparities, social determinants of health may just be as important within this population as well. Are there any data that have looked at this? Well, we'll talk about that in just a second. But it's also important to note that there's no data that demonstrates that young Black athletes have a higher prevalence or at more risk for genetic heart disease conditions compared to young white athletes. This was a nice review article that looked at this, looking specifically at ion channelopathies. And within this study, there was a meta-analysis which looked at an analysis of the mean allele frequencies for genes associated with cardiac channelopathies by race, and found actually that Asian individuals had the most genes associated with some of these cardiac channelopathy genes. And in other conditions, and again, we'll talk about long QT, data from racial groups are sparse, but for genetic cardiomyopathies, genetic analyses in Black patients are lacking. There's been a misclassification of variants disproportionate in Black patients. And for arrhythmogenic cardiomyopathy, the incidence in Black patients is unknown. So not a lot of data here, but certainly no data to suggest, specifically even in young individuals, that Black athletes may be at risk for these conditions. So now let's get to the data. Are there any data that have evaluated social determinants of health? Well, quite limited. This is a study from John Dresner's group at the University of Washington, and they looked at outcomes from exercise-related SCA in high school student athletes in the USA. These data were accrued over a 5-year time frame. You can see the demographics here, only 111 cases. But as you may expect, minorities did have lower survival rates compared to the white non-Hispanic student athletes. But they looked at outcomes specifically in the context of key socioeconomic factors: median household income, percent minority, and those who are receiving free lunch. And what they found, while not statistically significant, was a monotonic rise in survival for those athletes who either had higher median family income, were not a minority, and who were not receiving free lunch, which suggests that potentially social determinants of health may play an important role as it pertains to outcomes, even among young competitive athletes. So we can get even deeper into the discussion and ask the question, what about structural cardiac phenotypes? So as a reminder, we know that EICR is defined as the hemodynamic stress associated with exercise training that can lead to different cardiac phenotypes. For the endurance-trained athlete engaged in isotonic exercise, it's more an eccentric type LVH. And for the strength-trained athlete engaged in isometric training, it's a concentric LV remodeling type picture. Well, what about differences between Black and white athletes? So here the data really come from the United Kingdom and Europe primarily. These were all cross-sectional data sets that have looked at this question. This was an old study from 2008. They looked at 300 Black versus white athletes. Numerous sporting disciplines were represented, but what they found overall, higher LV wall thickness for the Black athletes. And really it was primarily just the Black athletes that fell within the gray zone of LVH, which we define as between 13 to 16 millimeters. These data were essentially replicated in young Black female athletes. Similar study design, similar findings, 240 Black female athletes versus 200 white female athletes, and higher LV wall thickness in the Black female athletes. Mostly falling within the gray zone of LVH were just the Black female athletes. The overall, the absolute wall thickness being smaller, but still the gray zone being defined here is between 11 to 13 millimeters. More recently, this was a neat study which looked at the impact of geographical origin. These were 1,200 Black athletes, a part of the Qatar National Olympic Committee, who were studied cross-sectionally by ECG and echo and compared to around 700 non-Black athletes from Northern Africa and Southern Europe. And they were interested in differences in abnormal ECG repolarization patterns and LV wall thickness. And what they found, the slide did not transfer over. But what we show here is that actually the Black athletes from Middle Africa and West Africa, those are the two red boxes, had a higher prevalence of abnormal T-wave inversions and higher LV wall thickness compared to the other geographic regions compared. And most recently, the question of mixed race athletes. Again, these data come from Sanjay and as well as Anil Malhotra, and they looked at 1,000 mixed race athletes. These athletes who self-identified one Black and one white parent, compared to a large similar cohort in number of Black athletes and white athletes. And they as well looked at differences in T-wave inversions and LV wall thickness. And what they found was a stepwise increase from the white athletes to the mixed race athletes to the Black athletes of a higher prevalence of abnormal T-wave inversions as well as higher LV wall thickness. Now, really, the compilation of all of these studies are certainly quite interesting, but there's some limitations. First and foremost, in the discussion, there's no entertainment of the potential contribution of environmental stress. So it was all felt that these were all related due to underlying physiological differences. And these are all based on self-identified constructs, that being race, of course, and there were no genetic admixture analyses anywhere incorporated in any of these studies. So a critical limitation. Can we say anything about the impact of environmental stressors as it relates to cardiac phenotypes? I don't think there's any studies out there except this one. This comes from my group. This study was led by Jason So. As many of you know, my group's been very much interested in maladaptive cardiovascular phenotypes in football players. And so we took the opportunity to look at differences in self-identified race phenotypes, specifically for the development of concentric LVH, which is a maladaptive cardiac phenotype generally driven by higher blood pressure within this population. But we also included median household income, which was significantly lower for the Black athletes. Now, this is a busy figure. I'll walk you through it. In panel A, what we show is that there was no difference in terms of the development of concentric LVH between Black and white football players. Really no surprise. Again, this is a population that is certainly at higher risk of developing this maladaptive type phenotype. In panel B, we see no difference in risk for the lineman player position. These are the big guys up front. Again, no surprise. These are the player position. This is the player position that generally develops this phenotype, certainly has the largest weight as well as generally the highest blood pressure. But for the non-linemen, you see that Black non-linemen were more at risk for the development of concentric LVH compared to the white linemen. And this was bore out when we looked at factors associated with the development of this phenotype. You see the race player position interaction, but I'll just call your attention to the bottom here. While this did not reach statistical significance, the suggestion that lower household income was also associated with the development of concentric LVH. So again, I think this just suggests that potential environmental stress actually may play an important role in terms of the development of specific phenotypes that we observe in athletic populations. So when I think of downstream bins of outcomes for athletes, of course, there's health outcomes such as sudden cardiac arrest or death, the development of cardiovascular risk factors, as well as different cardiovascular phenotypes. So how should we think about the socio-political construct of race and the relationship between, or the association between downstream acquisition of each of these three different bins? Well, I do think we don't want to ignore the potential contributions of physiologic stimuli, but clearly it would be inappropriate to ignore the potential contributions of social determinants of health. And really, to understand this complex interplay, this as well requires a better focus, better longitudinal studies, which are really controlled for all of these different variables to really better understand the relationship between race and then obviously these downstream outcomes. But there's an important clinical point to this as well right now. So I mentioned the 2017 ECG international criteria. These are the criteria that we use to interpret the athletic ECG. Well, how good are they? Well, the false positive rate overall is about 1%. And this is a general improvement, somewhere between 1% to 2%, a clear improvement over the prior iterations that were developed over the prior couple decades before 2017. But what about differences in interpretation between Black and white athletes? This is a study that we cite quite often from the UK, looked at 11,000 soccer players. And what they found overall was a false positive rate that is to be expected, about 1.5%. But you can see that false positives are almost double still for the Black athletes. And really that difference is pretty consistent when you look at prior ECG criteria across the board as well. Now, I'd just like to point out some key limitations of this study. Number one, these are all essentially men. And importantly, while a study looking at racial differences, over 90% of the cohort was white. But I think there's some critically important take-home points from this, particularly when you think about screening, and particularly when you think about the screening tool of choice are these international criteria. And when you think about screening healthy athletes and clearly unequal differences in outcome whenever you're screening white and black athletes, when you haven't taken into account downstream resources, clearly what can unfortunately happen is further marginalization whenever a certain group of individuals are screened more so than another group of individuals. This is something that we don't talk enough about, I think, within our field. And so I recently wrote an editorial with several colleagues of mine where we talk about this call for action and in terms of addressing disparities in sports cardiology. So it's not just the inclusion of social determinants of health and future outcomes and observational studies of athletes, but I do think in terms of the clinical care of athletes, we have to not only improve our workforce diversity, but we have to move away from race-based practices that we have. So talking about the quote, end quote, black athlete's heart or the black athletic ECG pattern, we have to move from the reification of a socio-political construct to a biological construct when we're dealing with different types of athletes. And this really came to the forefront recently. So everybody recognizes this is Bronny James, who, by the way, played yesterday, if you didn't know, successfully for Southern Cal. Well, after his sudden cardiac arrest event, there was a lot of media attention about the difference in terms of risk of sudden cardiac death between black and white athletes. And there were some groups, there was some attention calling for targeted screening. Maybe because we're seeing this difference, we should just screen black athletes more often, or we should screen basketball players more often, given some of the epidemiological data I showed. Of course, acknowledging that when you look at basketball players, there's a much higher prevalence of black athletes who play basketball, as we all know. Well, with this call, this was something that from a council standpoint, we pushed back on quite hard against, actually. And so this was something that I led as the current chair in terms of pushing back this notion of targeted screening for the reasons that we've talked about. We don't understand why there's a higher risk of sudden cardiac death in young basketball players. And by just jumping to a potential biological answer by saying, you know what, let's just screen all these individuals, this will help. Ultimately, what can happen is actually harming that population and further marginalization of young black athletes. And this is something that we have to push very strong back against. So quite a whirlwind tour. Just to summarize, medical paternalism in the practice of sports cardiology is outdated, and it certainly does not align with patient-centered care. There are data to support that athletes with cardiac disease, with underlying cardiovascular abnormalities, can participate safely in competitive sports. We need more outcomes data. As mentioned, I'll talk about ORCA in a sec. We have to have better generalizability, and there must be a focus on quality metrics with qualitative type research, improving the shared decision-making that we engage in with athletes. For the masters athlete, they aren't immune from cardiovascular disease, as we showed. They certainly harbor their fair share of traditional cardiovascular risk factors. The clinical significance, despite the masters athlete heart study of subclinical CAD within this population, is really still unknown. So shared decision-making also applies when we counsel this population. And remember, the worst thing that you can do is tell them to stop exercising or to significantly reduce the amount of exercise they're engaged in. We do have many uncertainties in this space. I'm very much passionate about this question of disparities, particularly among young competitive athletes. That's just one of many that we're dealing with. But I think the next 10 years in this space proved to be just as exciting as the last 10. And I think this acceleration in science is going to continue. And this is a really great time to get into the space of sports cardiology. So ORCA, this is the Outcomes Registry for Cardiac Conditions in Athletes. It's actually led at the University of Washington and Mass General. The PIs are John Dresner, Kim Harmon, and Aaron Bagish. Emory is a subsite. I'm a co-I within this registry, along with other sites around the country. You can read the inclusion criteria. We have a website that's easily accessible. But just a reminder, obviously, if you happen to take care of an athlete that may fulfill inclusion criteria that's already not within my own practice, please let me know. Really, it's going to be this registry that answers a lot of the question and can better help define the precision that we're looking for in terms of the counseling of athletes, a part of the shared decision-making process. With that, thank you for your attention. Any questions?
I have a question. Jonathan, Brad Leschnauer, enjoyed your talk. How do you counsel your aortopathy patients? I'll give you my take, which I learned from surgeons who I trained with, and it was just passed on to me, which is for patients who have significant aneurysms, but they're not very close to meeting surgical thresholds. I say you can do any cardiovascular exercise you want. Don't lift more than half your body weight. And I don't necessarily have strong data to support that. I know that certainly weightlifters have been shown to have an increased risk of dissection due to spikes and surges in the blood pressure, but I'd be interested in how you counsel them.
Yeah, no, thanks, Brad. That's a great question. And a few responses. I mean, obviously, when we separate out kind of the heritable aortopathy from the kind of non-syndromic, non-heritable aortopathy, I mean, there's some nuances to that question. Overall, I do think that, well, first of all, when you go back and you look at prior recommendations on this, probably too conservative. And certainly when we think about bicuspid valves and aortopathy, based on the degree of dissection that we see in autopsy series of athletes who have unfortunately had sudden cardiac death, and knowing how common and how prevalent bicuspid valves are, I think we can be more lenient there for sure, certainly based on what was recommended in 2015. As the aorta gets bigger, obviously there is certainly more of a conservative and more concerned approaches in terms of how we manage that. From an aerobic exercise standpoint, I'm a little bit more lenient as it pertains to kind of dynamic exercise. And my kind of line in the sand has always been around 5 centimeters is whenever I really get nervous. And once I hit that threshold, I'm calling you up. And I'm probably actually thinking about fixing it even before we hit a surgical threshold, just based on the high-end exercise habits. For the strength athletes, similar kind of line in the sand around 5. The counseling of how much weight to do, I think the challenge, though, is whenever we say 50% body weight, we have to remember that that can mean different things for different people, right? So if you are a former lineman, half your body weight is, roughly, I don't know, 150, 175 pounds, they can probably curl that with one arm still, versus somebody like me, where I don't do a ton of weightlifting, and maybe half the body weight, if I had an aorta of 4.8, would be very reasonable. And so I think that does come into play, kind of the type of athlete that you are in terms of how you counsel that. I'm a little bit more kind of general. I certainly don't endorse doing kind of max RM type weight lifts. I will generally say, if you are straining, if you need a spotter, if you are doing a set of whatever and you're getting to the last few and it's a strain, that's maybe whenever you kind of call it. So it's a very much more of a qualitative description rather than a set number, because I think that set number can not necessarily be relevant or appropriate for all types of individuals. And I've certainly had that. I've had individuals come in and, big weightlifters, and they say, oh yeah, my cardiologist previously told me I shouldn't lift more than 50 pounds. And they don't know what to do because that's like nothing for them. So, I think it's very much individualized sometimes.
And one more follow-up, that ORCA registry, does that include aortopathy?
Yes.
So when I get a young patient that presents with a dissection or something, I should notify you.
Yeah, let me know. I mean, again, there are some specifics in terms of, over time, hopefully we can expand, but for now it is very much kind of the individual who's competing at a more competitive level right now. But you can definitely run it by me for sure.
Okay, thank you.
Dr. Clements.
We did have, that was great. I was listening outside there. So, we did have one young individual who's a weightlifter and pressing a very big load, and he developed SCAD. And of course, that's on the list of things that cause SCAD.
Yeah.
I don't know about our friends who take their exercise to the absolute limit, as you touched on all that stuff. But so this SCAD came to mind in this individual who was doing that. Anyway.
Yeah, no, and
great presentation.
Thank you, Dr. Clements. SCAD is a tough one. I mean, we just don't have a ton of data there, and obviously we're going to be talking about that in these forthcoming clinical considerations, as we're calling them. And for SCAD, what you'll see is that it'll be kind of noted in terms of what we say. We just don't have a lot to guide that specific population. That's a tough one.
Jonathan, Andy Smith. There are a lot of trends in a good way towards putting shared decision-making into clinical guidelines. The recent atrial fibrillation has some things related to shared decision-making. I don't think I'm very well trained in actually how to do shared decision-making, how you deal with when there is uncertainty of information, ability to know the full scope of the information, quote, well, this is what, allowing the patient to help make the decision about what they're going to do. Physicians putting it on the patient and families about making decisions about things without them necessarily being fully informed. So I just would appreciate your comments related to that, and then also related to liability issues and things that you might do in your documentation in the event that there is an event later and someone comes back and says, oh, well, he didn't really inform me of this. So just, it's a broad area. We're moving towards that in medicine, in cardiology, and I don't think we're very well trained around it.
Yeah, I think I'll actually start with that, because that's a really important point. And I think even in us in this space, acknowledge that shared decision-making has never been tested as it relates to from a legal standpoint in a bad outcome, where somebody has kind of gone back in a sports eligibility discussion, and you went through the process and they unfortunately had an event, maybe they died. That hasn't happened yet. It's going to. I mean, it's just inevitably it's going to happen, right? And to some regard, I don't know what's going to happen with that. I see Dr. Dickert here in the audience, and certainly he's our shared decision-making expert. And maybe we can ask him to chime in, because just from an overall standpoint, he may have some comments there. But I will say one of the important points for the process with athletes is that, and again, I don't know if this is going to help mitigate that potential concern, is that shared decision-making is never like a one and done thing, right? So, when I see these individuals, I'll tell them up front, within the first hour that we spend. It's never a 30-minute visit. Like, okay, so what are we doing here? And then we're all good. We're all set. And, it's a standard office visit note. And they said they wanted to play. They accept they could die with this. We're all good. We never make the decision up front. It's a series of meetings. It's a series of getting to know the family, getting to know the athlete, and specifically for competitive athletes, it's a little bit different if it's a recreational athlete, but for the competitive athlete, you have to involve the other stakeholders. And so the first couple of meetings, it's the athlete, it's their family, and then you bring in the trainers, sometimes the coach, sometimes the AD. And then after that series, obviously the documentation of everything that you talk about, goes without saying, but I think it's that series of integrated meetings where everybody has a chance to kind of have a discussion, kind of hear what people are saying. And then even a subsequent follow-up meeting after that, it's several. I mean, I can't quantify the number of hours that I spend, with each and every one of these discussions. And then it's also important to note that it's also not a one and done for 1 year. I mean, we go through the same exercise every year, and that's something that we talk about. It may be redundant in the conversation, but we go through the same series and always outlining what is the biggest risk here, and with most of these conditions, the risk is sudden death. And of course, we've had recent contemporary cases now of that happening, where you can integrate that into discussion to where everybody is on the same page. The other thing that makes it a little bit unique is the third party. So it's not just kind of what the athlete wants to do. It's ultimately in the end kind of the primary stakeholder, which is going to be the university or professional team that has kind of final arbiter say with that. I can't remember the first part of the question. Before that, I thought that was the key thing, but I forgot what else you had said.
No, I think that's it. It's just that, this term's popping up, and we don't have much training in what it really is.
But I will say, I mean, that's something that Neil and I are actually quite interested in. I mean, we understand too that and we actually have some good preliminary data just with interviews with random sports cardiologists around the country about how differing opinions and views there are about what does shared decision making even mean, and certainly how to interpret the various processes of this. So it's I think we can accomplish both at the same time. This is clearly the better way to do things than the way we used to do things. But at the same time, it is very much a kind of Wild West out there in terms of how people do things. And even at expert centers, like there's no doubt that people who are considered experts in the field probably have differing ways they do things. And so it is really important. And it's not just for competitive athletes, but even whenever you're counseling your other patients in your practice as it relates to exercise. As mentioned, these masters athletes are the ones that everybody sees. They don't just come see me. And a lot of them have MIs and want to get back to, running marathons or doing tries. And so how to go through the process with them would be nice to really have some kind of quality there.
Yeah, I just add one really quick thing, which is that, as you mentioned, we've been working on developing some projects in this space, and is I think really exciting. Andy, one of the things that we found that Jonathan mentioned, we have interviews from around the country. One shocking finding in some sense is the extent to which when you ask people who do this regularly to talk about what they think that means, something that often doesn't come up is asking people what the activity means to them. Or that's one piece that I think is just intrinsic to this, and especially in the sports piece, maybe even more than a lot of our other contexts. You can't make a blanket statement of a sort of risk value kind of trade-off without understanding what the activity means to the patient. And these are really activities that are intrinsic to their being. And so that affects how they make risk-benefit trade-offs. And I think we have to acknowledge that. The other piece is that I think situations of profound uncertainty, we have this tendency to offload decisions to people. And the truth is, like anything, most good decision processes are helped by data. So this is where, the data that Jonathan are talking about gathering are just so important, because we have to have better parameters that we can give people.
Yeah. All right. Thanks.
The preceding program is copyrighted by Emory University.